All right, folks, we're back. And take it off mute. All right. That was Dr. Pez and everybody that was watching that. We had a little bit of an issue there with some technology and just being kind of slow. I think I got those issues hopefully resolved. So now we have Austin Wolfe here of the Joplin Police Department to discuss, well, what's on the screen there. I can't read it. Responding to medical emergencies with JPD.
Hi, everybody. For those that don't know me, my name is Austin Wolfe. I'm currently the training sergeant out at the police department. Um, I got asked to put together a class here, and I got to thinking, what am I going to teach you guys that you already don't know, and who am I to teach you anything? So I got to looking over kind of what's been done at the Joplin Police Department since I got hired and kind of where we're at today. And a lot of this is just kind of education. That way, you guys kind of know what we're doing on a day to day basis and kind of looking for your help in a lot of areas. But to get things started, I started the police department a little over 13 years ago. And when I did, we noticed an immediate problem that our officers weren't getting trained. They would be in a first responder class in the academy, but it became very apparent that guys weren't getting medical training that were 5, 10, 15, 20-year veterans of the police department, which made us not treat patients or each other whenever things happen. So we evaluated everything we had. We started putting classes together over 10 years ago, and we kind of came up with a list of priorities for our department. Now, this is, again, Joplin Police Department, so if you deal with outlying police departments or sheriff's offices, they might have different priorities or kind of a different training outlook when it comes to this. But overall, what we're doing it this is an exact slide that I pull off from all of our new hires that I teach. And we're not the best, or we have our problems, and we really try to get better at them. But this is kind of a list of priorities that I give our new guys when they're responding to medical emergencies or traumas or disturbances. And the reason why secure the scene first is in red is because I explained to all of our officers that you may not get past secure the scene first. And if that's all you do, then your job is complete. That way we can get you all in there, keep the scene safe, and let you all do what you do and save lives. But giving detailed radio reports, I've got some stuff to go over as far as communication and our agencies together. But the more information you guys have responding, you guys can align your resources appropriately. Obviously, preserving evidence and providing emergency care. One thing that we're recently teaching all of our new guys is the necessity of providing emergency care, especially if it's an officer-involved shooting and the suspect goes down. There's a recent Supreme Court case in this part of the country, which is generally very pro-police, but they came down in the Eighth Circuit here a few years ago, and they stated that officers shall provide emergency care, and they're holding officers accountable at the Supreme Court level. So that's a Supreme Court case that came out of Ohio, but that's something that I use in all of our classes that I explain. You can't run from this stuff, so you might as well get good at it. And then provide assistance with family members or bystanders. I think this is nothing new, not a new topic for any of you all when it comes to responding to very volatile medical situations. But that's going to be secure the scene first, and we all know what kind of an issue that is. And I try to explain that to all of our new guys coming in. So just to give you guys an idea of what our education when it comes to medical stuff, most of you all are familiar with the police academy, and every officer that goes through the police academy receives a first responder certification, and they have to receive that in order to pass it. It's like your hazmat awareness to move on in the fire academy. But whenever we hire a new officer on, we put them through basically a refresher of a first responder class, and then we transition into a tactical medical class. And that tactical medical class is also given department-wide. And during that, we are focusing on the big stuff, and that's basically control the bleed. Unfortunately, we live in an atmosphere right now where cops are getting shot, and we're having to deal with that. So focusing on what's going to kill us now is the basis of that class, and doing it as safe as possible. And then every year we are constantly updating our officers. This year we're hoping to get a skills lab into where we're working with some medical equipment and checking guys off on their basic medical skills. And if you guys pay attention to Facebook or any other social media, our staffing's an issue. So about the time we have gotten our department entirely trained in 2018 to 2020, we lost about 45 to 50% of our police department just from people leaving. So it feels like just as soon as we get guys trained up, you all get to know them, and you feel comfortable talking to them, we're losing them. So any assistance you can give, please do. I know our guys are very eager to start learning new things, and they're going to pick your brain if you have the opportunity to take a second to say, hey, good job, or hey, next time you deal with something like this, you might consider taking this action. We've got a lot of proactive people when it comes to providing medical care. Another part of our education that we have unfortunately had to implement here recently in the last few years is officer down education. And this particularly screams out to you guys, because where we have failed, and we're not the best, and we fail to train together, all three of our entities, is officer down stuff, because the dynamics completely change whenever one of ours goes down. So in order to incorporate this, we've had to add in some big things into how we're going to respond to an officer down. And the first topic is weapons. And let me tell you, trying to get this topic passed through with guys that are 15, 20-year veterans is a really big deal. I got a lot of pushback until I explained it. But anybody that's been through any sort of a tactical medical school understands one of the first priorities in treating an officer is removing their weapons. And I'm preaching to the choir, but you all understand the concept of blood loss. You understand the concept of concussions or head injuries, where all of those can make an officer have an altered mental status, and we certainly don't want anybody with an altered mental status in possession of a firearm. And studies have also shown that if an officer goes down in a fight and becomes unconscious, they, more often than not, when they regain consciousness, they wake up still mentally in that fight. So one thing that we're really pushing with our supervisors and officers is if there is a officer with a critical wound or an injury that's going to require narcotics to take care of the pain, we get those weapons removed from that officer as fast as possible in the safest manner as possible. And it may be you guys reaching out to another officer or a police supervisor saying, hey, can you take his weapons or her weapons from him or her? Because we do not want them waking up in the back of your ambulance or on the scene somewhere, believing they're in a fight, and instantly go for their gun. So we need your help to do that. This is a trend that has been going on for years, and it's something, the seed's already been planted on our SWAT team. That's what our SWAT medics are going to do for our guys if they go down. But getting that to be part of our culture has been kind of tough. There's a lot of pushback because you never give your weapon up as an officer, and to voluntarily just give it up would be tough. So I'd recommend you get a hold of a police officer or supervisor on scene. I don't recommend you guys start reaching for their guns or anything, especially if you don't know the officer. Considerations for transport. This is also a very upcoming topic in law enforcement. If one of ours goes down, are we going to wait on an ambulance or transport them directly to the scene? And again, I'm preaching to the choir here, but you all know the complications that come with throwing somebody in the back of a car, driving 100 miles an hour and arriving at the ER without any sort of notification or ongoing care. Well, we've been preaching this for a while, but it wasn't until recently. This actually happened at the Joplin Police Department. We had a citizen sustain a femoral artery bleed, and due to some communication issues between dispatch and the officers and the typical stuff, the ambulance didn't arrive. They waited on scene for probably 7 or 8 minutes, and they made the decision to transport this citizen to the hospital in the back of a police car. Well, just as you all know, there was a lot of problems. This was 5 o'clock in the morning, so it was dark. It was a full-cage police car, and we transported this citizen to the ER at Mach 7, and the officer that rode in the back with the citizen had to hold a flashlight in his mouth while he was trying to provide care. Well, obviously, he couldn't provide care to the wound and maintain an airway and do a secondary assessment. So what we're doing, moving to the third point there, what we're doing is we're trying to get all radio frequencies put into at least supervisors' radios so we can go direct with you guys. We can go direct with the hospitals and let them know, hey, we have a priority 1 trauma coming in. Because when that police car arrived at the ER doctor walked out, and the ER doc thought that he was going to be making contact with a priority 1 medical. That was a code, and it was a police car running code with a priority 1 trauma in the back. So you could only anticipate what had to spin up right quick and in a hurry on top of the incoming code. So those are things that we're working for, and but it's important that you guys know where we're coming from and why we do it. And if we can get communication with you guys, if maybe we can set up ALS intercepts, or you guys, we know how long it's going to take for you all to arrive on scene. So every one of our officers are issued these. During my class, whenever they first come in and I intake them, and we put them through that tactical class, they get one tourniquet, one set of chest seals, and one Israeli bandage, and they have to use these. They have to show proficiency in these before they're allowed to get out of the class. Now, one thing I will direct your attention to is the chest seals, and this is going to directly affect each and every one of you. Due to COVID, like everybody else, a lot of our budget got shut down. And when our budget got shut down, we stopped ordering medical supplies other than tourniquets. And so we had to improvise. And how we improvised is I'm issuing AED or Zoll fast patches to people that don't have the chest seals. And so if you arrive on scene and it's a penetrating chest wound and you see fast patches on them, take a look and make sure the cords aren't cut. That's going to be your tall tale sign that, hey, the cops put that on there as a chest seal if the cords are cut. So we're going to be getting more chest seals here soon, but I just want to direct your attention to that. I think Dustin's done a really good job telling the fire guys that we're using chest seals as an alternate to, we're using fast patches as an alternate to chest seals, but hopefully we're back to chest seals here pretty quick. Also, what we're teaching our officers, and we're going to look at how dispatch is set up in just a second, but this is the information that I want you guys to know that we're teaching our officers. So if they arrive independently on a scene, just driving down the road and roll up to a crash, or they're first on scene on a medical, this is the exact information that I am teaching to get the information out to you all. This is an exact slide brought off my new hire PowerPoint. I think all this is pertinent information. This is pretty well everything that you all need when making a response determination on resources and priority. Because a lot of times our guys aren't going to tell you to run emergency or not. But I think with the above given information, you all can make that response decision yourself. So if we move on to the next slide, this is our biggest problem. I think this is the standard operating protocol for local dispatch agencies. And probably one of the biggest reasons why we are not getting the information out. Whether the information's going from the police officer to Joplin to Jasco to the ambulance or the opposite way, we're just running into a whole lot of problems getting the information out. We might say it's a priority one and then we get a non-emergency ambulance. So I think what's going to bridge that gap is just opening up communications with our radios. And we've always been so worried about getting on somebody else's radio frequency, but I've gotten on Fire, I've gotten on Mets, and I've gotten on on Joplin Med and gone direct, and I can't explain to you the benefits of that. I think there's definitely time and places. All right, so like I said, we're not perfect. We're not a perfect agency, and I'm going to tell you right now where we're falling short as far as taking care of you guys. And this is where I need some help. Medically clearing. As a supervisor, as a patrol officer, I have constantly over the years read reports where they said that Metz, Newton County, or Joplin Fire responded to the scene and they medically cleared the person to go to jail or to allow to walk off. When you guys are going up to those scenes and you're going out on taser deployments or whatever, you guys might just make a note in your head that, hey, we're not here medically clearing. The only person that can medically clear somebody is a physician. We're here to let you know that we don't see any major life threats or the vital signs are within normal range. But, getting medically cleared is not something I want in a police report. That's not something you all want to have to go to court and testify on and explain, hey, I didn't medically clear anybody. So if you hear that terminology floating around on a scene somewhere, you might just make an effort to go, hey guys, we're not medically clearing them. We're just letting you know we don't see any major life threats, or however you want to word it. Staging. Yeah, we're terrible. I get it. I'm trying my hardest. I know you guys at 3 o'clock in the morning or when things are getting busy, we are horrible about telling you all to clear, to come in. Well, I think we're pretty good at telling you to come into the scene because if we see blood, we tell you to come in. But telling you all can go back in service is tough. The recommendation that I have for you all is just, ask dispatch every few minutes, what's the status? Do we need to respond in or whatever? And they're going to check with our officers. I hear it all the time. Do you need medical? And once they ask that question, a lot of times they'll say no. But sometimes, we just go to those disturbances where it takes us an extended period of time to get things settled down and secure before we can have you guys come in. But again, checking with dispatch consistently will probably alleviate that staging issue. Poor assessments. We get fixated as an agency, as officers, on assessments. And we had an officer-involved shooting here a few years ago where our guys did a phenomenal job treating the wound, saved the guy's life, but we missed a bullet hole. We never saw it. That wasn't part of the medical treatment they were providing. They were trying to get the bleeding stopped, and it wasn't until Mets arrived on scene and was transporting they found an additional bullet hole. So if we say, hey, we don't see anything or whatever, I always encourage you guys, please do a secondary assessment because we may be missing something. One thing that you guys probably get confused on is us not requesting medical at the scene. Our practice is if we believe that there needs to be medical care done, we need to be calling for EMS and fire to respond directly to the scene. We don't need to handcuff somebody, take them to jail, and then go have medical meet us at the jail. Obviously there's Murphy's Law, and sometimes on the way to jail they start complaining of chest pain or whatever, but if you guys get a scene call instead of just not checking them out at the jail, you kind of understand why. I would much rather have somebody checked out at the scene and take them to the hospital than drive them all the way back and delay that care. Vehicle placement, fire guys, I know this is one of your biggest pet peeves. I get it. I can't emphasize that enough. As a street sergeant, I always try to get my guys to move their cars out. I think a lot of times that we feel like that we've got supply line in our trunks, and so we're going to pull right up to the front of the house that's on fire. Again, we've had a huge switch in employment. We've lost a lot of our guys. So if you all get the opportunity to just kind of explain, hey, if you can move your car not in front of a house fire, or for the ambulance folks, our patrol car sitting right next to the crashed vehicle isn't doing you a lot of good as far as extrication and treatment. So that's something we've got to work together on, and I know our guys would be really receptive if you guys explained, hey, we need to work on your vehicle placement, especially on scene. And that's an ongoing talk that it's almost one of those talks that we have to have every 6 months or so, because we forget, we don't go on a lot of fires, and when we do get there, we forget about those conversations. All right, here's where we need your help, guys. From working on an ambulance, doing the fire thing, and being a cop, I need your help. Oftentimes, we're too scared to say something because we don't want to be wrong. Let me tell you something. You guys are some of the best crime scene investigators out there because you all are looking for different things. You're not fixated necessarily on what we're looking for. But I don't know how many times that there's been an ambulance or a fire truck or both staged and they've seen the suspect run from the scene, or they see somebody skirting shadows or whatever. Please report that stuff. You guys might be the only people that are catching a bad guy or helping us, catch the bad guy, because you guys got extra eyes. Evidence, I don't know how many times I've walked into a house or a crime scene and a paramedic or a fireman has pointed out, hey, have you seen that over there? I do ask that you don't make a big deal in front of, like, if there's potential suspects there or victims, but definitely don't assume that we've seen everything. Again, a second set of eyes is always better, and you guys are looking at different things. Child abuse and elder abuse. We have got to have your help on this, guys. I spoke to Luke Stahl, who's currently in investigations, and these are the two big cases that often fall through. And we're going to talk a little bit more about those in just a minute. But if you guys suspect something, get us on the horn. I'm going to tell you a story here in just a few minutes where we got really behind on an elder abuse. But you guys are professional. You guys have seen a lot of stuff. You guys are going to pick up on stuff that the cops won't when they're there. And we need your eyes. Your opinions are great, but you guys also come with some fact-based opinions. So one thing that I noticed as a detective supervisor, a detective, is that overall, fire and EMS are really awesome at crime scenes. You guys walk into a crime scene, you guys are very conscious about how you guys are handling it. But again, there are some things that we could go over that, you know, might help you out. And I will tell you this. Every time I was an investigative supervisor and there was a homicide or a serious physical assault, the first thing I would do is get a subpoena and I would go down and get police and fire reports. So when you guys are responding to crime scenes, the first question you got to ask yourself is, why am I here? Okay, am I in there to provide patient treatment, or am I going to do a J4 confirmation? You guys have all been to crime scenes where it's been very minimal or very large crime scenes. If it's just a confirmation of an asystole, just to get a strip to make sure they're dead or whatever for documentation purposes, I don't think we need an engine company and 2 or 3 EMS personnel. And this is all for just keeping the crime scene as it is. I mean, if it requires more than one, absolutely, without a doubt. The difference is everybody that goes into that crime scene, we're going to get their name, and you run that risk of having to testify. And if we're going to talk about preservation in just a second. But if you don't need to go in, that's one area I would strongly recommend. Just go ahead and just stay outside. Cleaning up the crime scene. I think overall we're really good. At least when I worked on the ambulance, I think we were pretty good about cleaning our messes up because, you know, we didn't, especially if we worked a code or something, that was just courtesy for the family. But if just leave everything you leave there, the trash and everything. But at the end of the day, it's life over evidence. So, I mean, if you guys are picking stuff up and moving stuff and stuff gets messed up, it's always life over evidence. Here's a big thing. We're bulls in china cabinets a lot of times. Furniture. A lot of times we have a tendency to grab a couch and throw it out of the way, or living room chairs or beds. If it doesn't need to be moved, guys, from a crime scene investigator point of view, please leave everything as you see it. Because we have to reconstruct that. And we're going to come back and interview you and say, hey, how was this? When you walked in, how did you move it? And a lot of times we forget. And at the end of the day, we're going to have to testify in court and reconstruct that crime scene based on what we saw when we walked in. Weapons. This is a big scene safety issue for everybody. And I'm going to tell you this. This is a big issue we work with our officers every day. And weapons, if they're not going to hurt you, leave them alone. That is huge and goes against everything you've been taught. But we worked a shooting in the Walmart parking lot at 15th Street here a few years ago. And the first responding officer walked up, and the driver was sitting in the driver's seat, and he was clearly J4, if you understand what I'm saying, but there was a gun sitting on his lap. So they busted the window, and they pulled the gun out. Well, later down the road, that causes some problems because we couldn't reconstruct how that gun was laying. And, of course, they said they made it safe, but was there really around in the chamber? And that just causes investigative problems later, which could cause court problems later. Bodies. If you don't need to move a body, please don't. I can't emphasize that enough. When we get somewhere, if they're clearly J4, let's leave them where they're at. And, you know, I put shell casings up there, but that goes with any sort of evidence. I mean, if you've got to touch it, you got to touch it. Life over evidence, and I will say that and back it up 100 times over again. But if you don't have to touch it, please leave it alone. So the bottom topic is covering dead bodies. So here it comes. This is the gorilla in the room, kind of. We as EMS fire guys want the most privacy we can for not only the victim, but the families. And I get it. Especially if it's an outside DOA or something like that. I absolutely get it, and I know where our heartstrings go. And I'll be the first one to say, let's get this body covered up so people can't gawk. We got the news media coming or whatever. But here's the deal. Covering up bodies with blankets is probably one of the worst things you guys can do from an investigator standpoint. And the reason is there's a loss of transient evidence. Okay, we're taking a non-sterile blanket that comes from the back of a fire truck or an ambulance, and we're laying it on top of a body, which technically is a piece of evidence. We are now introducing additional evidence to the scene, whether it's hair fibers, DNA, Maybe there's blood on that blanket or whatever. Even if it's a rain blanket, we're still introducing stuff to the scene. And transient evidence is the evidence that will be lost if, can easily be lost. So if we pull that blanket up, we're losing hair follicles, we're losing potential DNA, or we are contaminating. So in order to avoid that, the one thing I'm going to ask is that I absolutely believe in privacy and doing our best to protect the scene. If we can maneuver vehicles, if we can set up sheets standing up around the body, or do something to protect it. Now, detectives have a tent that they'll bring out. That way it keeps the onlookers and the rubberneckers away from being able to see the body. But one thing I'm going to ask you guys to do, and please do not use a blanket to cover a body. So, like I said, you guys have become some of the best criminal investigators that we have, because you come into a scene and you see things from a different angle. You guys see things that we're not necessarily looking for. But as whenever I was a detective supervisor, again, I would get subpoenas. I'd pull your fire reports. I would pull your EMS reports. And your reports, I'm telling you, are awesome. But a couple of things that I would, and this is consistent, a couple of things that if you're looking to improve your report on, or maybe not get hit so hard in a court case, especially a criminal case, just keep in mind your report. It's going to save you from cross-examination and looking incompetent. And what I mean by that, using different things, like very, very common in EMS reports. The patient was intoxicated. Well, that doesn't tell me a whole lot, because we don't have a device to measure their intoxication level. And intoxicated can mean anything. And if you look at the Missouri DWI statute, intoxicated could include caffeine. It impairs somebody. It could impair somebody. So what we use in law enforcement, if somebody says they're intoxicated, we use the word intoxicants. I could smell the odor of intoxicants on their breath, and we describe what we see. Did they have slurred speech? Were they unable to balance? Were they having to use nearby objects to steady themselves? Were they unsteady on their feet? Things like that. We describe the word intoxicated by the actual actions. I see a lot of EMS reports, fire and EMS reports, that just say the patient was violent. To a judge and a jury, and 5 years later, that's not going to mean a whole lot. When they ask you to explain specifically how were they violent, unfortunately, you guys are in a line of work that people aren't always happy to see you, which is hard to believe, but they're not. And we deal with some very violent people, whether it's verbal or physical. So we've got to describe that. We have to say, they were actively aggressing me, or throwing punches, or whatever you want to say, but just the word violent is pretty bland. You guys are pretty awesome at citing how people are dying. Cool, pale, clammy, blood loss. You guys are awesome at that, but that's another one of those words that you see from time to time in EMS reports, that the patient was dying. But if you guys can further explain it, that's awesome. Also, your report is an awesome place to report mistakes. We make mistakes all the time in crime scenes. If you guys moved a couch, which isn't necessarily a mistake, but if you move the couch, that's an awesome place to put that, because whenever I'm going back as an investigator and I'm looking at your report, I can say, oh my gosh, that couch was moved. That makes perfect sense. Or that gun was moved. You felt the need to move that gun. Did you use a gloved hand when you moved that gun, or did you have somebody else move it? That is an awesome place to put that explanation. So again, I'm kind of moving on to the documentation that I've seen, guys. Overall, your guys' documentation is great, but these are some areas where you're going to get hung up in trial. I've been hung up in trial on stuff like this, so I'm telling you from personal experience, from my report writing. But the house was dirty and deplorable condition. Describe that house. How was it deplorable? How was it unlivable? Was there feces everywhere? Was there cockroaches running everywhere? Was there mold? Was there... You name it. You guys have been in those houses, and there's not a word in the English language that can describe some of these houses. But if you specifically cite those, that's how you're going to recall the events, especially if there's a criminal charge. Personal observations versus factual-based observations. The patient was intoxicated. Going back, how were they intoxicated? I mean, it's easy to put they were intoxicated, but if you get asked on the stand, well, what were they intoxicated on? And one of the typical things that paramedics and even I in my paramedic reports put in was ETOH. ETOH was on board. And they're going to ask you, how do you know that? Well, I could smell it. Well, here's the kicker. What does alcohol smell like? True alcohol does not have a smell to it. So that's where they hem up officers in DWI trials and things like that, is what they put, I smelled alcohol. No, you smelled intoxicants or the intoxicating beverages. And then further explain the actions. You know, going back up to the scene documentation, we had a elder abuse that fire and EMS responded to here a couple of years ago, or a year and a half ago. EMS went in, documented the house was just in horrible condition, and they left. Well, the hospital called us because we hadn't followed, or Health and Senior Services called us because we hadn't been called to the original medical call. The elderly person got sent to the hospital and later died. Health and Senior Services were contacted because the lady was malnourished. We, of course, have to spin up a homicide investigation. And so we begin a homicide investigation, get a warrant for the house, go into the warrant, and the house is spick and span to the point where you could probably eat off the floor. In that particular report, you know, it was cited that the victim was malnourished and the house was in horrible condition. But when we went back in to take pictures of the house, it was in great condition. There was nothing that cited exactly what was going on, and then the word malnourished, there wasn't a whole lot to go on that. So it's kind of like saying intoxicated. If they're malnourished, you know, cite how, please. That just absolutely helps us. So moving on. So I can't say this loud enough, but whenever you guys are responding on the elderly or a child, we all want to put the bad guys in jail and help the victims. And I can't tell you how many times that your police or your EMS reports or your fire reports are the only thing speaking for that victim. And I say this because if we go on a child abuse, you know what our hospitals are likely going to do. They're going to fly it out. And I'm only going to have a testimony from a doctor or your ambulance reports to make the determination whether we suspect child abuse or not. And if, you know, unfortunately that child dies, we're really going to need your observations to help get good prosecution. So as we talk about crashes from the law enforcement perspective, there is no reason in the world why we're not working better with you all. And I talked about car placement and stuff like that. But again, we all want to help the victims and put the bad guys in jail. And I talked to Sergeant Jared Delzell yesterday and told him that I was teaching this class, and I put in this because I asked him, where are we failing in our traffic investigations and prosecutions? And it's the serious physical and fatal crashes. And so I understand that you guys come from a different perception on crashes than we do, and I get it. I just ask you guys to please just use this as a template, if you will. Scene safety above all is the biggest thing. But when it comes to these major crashes, our scene is about all the evidence we're going to get for the most part. So here's some strategies that in the back of your mind, just kind of, you guys are going to understand where we're coming from and what we're going to do after you leave and what we're going to do to try to get the bad guy in jail. So if you believe there's a chance for serious physical injury, and by state statute, serious physical injury is basically a debilitating injury of any kind, and for an EMS fire perspective, any kind of disability that you guys could potentially see. One thing that Sergeant Delzell asked me to talk about was the no absorbent, if you can help it. We use scratch marks on the road, and I'm not familiar with all the traffic terminology. I'm not a traffic guy, don't claim to be one, but they use everything from paint transfer to gouges to scrapes and everything. and they measure those out. They take photos of them, and every piece of that car, for the most part, is measured and photographed. And if sawdust or any kind of absorbent goes on the ground, then that's going to inhibit our investigation. Obviously, scene safety first. So the next one is don't cut the battery wires. This is actually pretty cool, and I didn't know this before until I became a cop. But if possible, we don't want to disconnect the battery. And if we do, try not to let the wires arc. And the reason is that we have a device at the police department that we can go in and get crash data from that vehicle's memory days after the crash. We can go in and see how fast the car was going, when the brakes were applied, when the airbags deployed, the whole 9 yards, and we can get a digital readout, which if it is a serious physical injury or a fatality crash, we will have that. And this morning on KZRG, I heard that there's an Oklahoma person just recently charged with manslaughter, and they estimated the speed at 90 miles an hour. Well, I'm assuming that came from the scene investigation. So I got secondary collisions. I totally get it, guys. Totally get it that we've got to keep our EMS, police, and fire absolutely safe on scene. But there is a statewide movement that the state is coming in, and I can't remember the acronym, but they're coming in and they're going to start holding agencies responsible for secondary collisions for blocking traffic when that wasn't necessary. And I'm more speaking like towards I-44, where we've got 70, 75 mile an hour cars or faster coming up on us and causing secondary fatals. So if we get out on the interstate or whatever, if we can keep a working lane shut down and a traffic lane shut down or opened up, we got to try to keep that traffic flowing. But obviously, scene safety and the victim's health is our primary goal for all of our entities. So if you've got to shut it down, you got to shut it down. You might just let dispatch know to let us know, and we can get the signs shut down on I-44 to start detouring traffic and getting people to slow down, and we can get some other agencies in. But just some ideas, food for thought for y'all. So here's some stuff when I talk to firemen or paramedics. Here's just to end this up. These are some JP practices that a lot of people don't know about, but for people that haven't been around an ambulance, if you see an officer get in the back of your ambulance and ride to the hospital, it's to hopefully keep you out of court. It's so we can have an accurate account of what happens back there. If somebody makes a dying declaration or a spontaneous utterance, we can put that in our reports. So it's not uncommon. If it's a serious physical injury or something major, we may put an officer in the back of your ambulance just to continue the documentation process or the chain of evidence. In the event that you all respond to a DOA and get there before us, I often hear fire guys or EMS ask for a supervisor. Our automatic response for a DOA is one officer and one supervisor. And depending on how busy we are, you may get one before the other. Who knows? Or at the same time. And also, something that we've added to our response criteria, any child medical calls generates an officer response. So if we go to a seizure or whatever, or you guys go to a seizure or whatever, we're going to get that call. And hopefully we can get there in time. And that's just one more check that we do for possible child abuse. And it's proven to be a very good response tool. Guys, that's all I've got for you. Please don't hesitate. If you got questions, please
Just keep going. We're way behind.
please let me know. So if you guys need anything, come out to the training center. If you got questions, email me or get a hold of Scotty or Jeff.